Hello friends, I'll be giving an overview on the CRBSI or CLABSI. So both are same. Central line associated bloodstream infections or catheter related bloodstream. So these nomenclatures are used more as a screening. When you use more as a surveillance, CLABSI is used. From the clinical standpoint, CRBSI is used, but for intensivists, for all practical reasons, they both are the same. So I'll be taking you through the brief overview on this whole topic, which is, I'm sure, very useful and valuable for all our DRNB trainees and other intensive care trainees. So the topic that we would be covering is the burden, the epidemiology of CRBSI, and what are the risk factors and pathogenesis. So that is one component. The second dimension is most important for all the trainees. You need to know what are all the guidelines that are endorsed by the standard guidelines that have come out to prevent CRBSI. Our whole effort should be to prevent CRBSI. So obviously, we are not talking on treatment. Then we'll talk on what are the newer aspects that have evolved to prevent CRBSI. So role of technology in preventing. So these are the three things that we would cover. So if you look at the burden of endemic healthcare associated infections, when we say healthcare associated, where patient has been in proximate sort of a environment of the healthcare within 90 days, and they develop infections, they constitute healthcare associated infections. So if you look at the burden, the big bubbles, as you see, is more than 10. And the orange bubbles are all the adult patients. And if you see, India has sort of a big burden of healthcare associated infections. And so are the Southeast Asian countries and some in the Middle East. And if you see, only small bubbles seem to be there in Europe. So this is the burden. So India is burdened with healthcare associated infection. That's the summary. And if you look at the middle income countries, healthcare associated infections, if you see, these are reported as all the healthcare associated infections. If you take CRBSI or if you take UTI or if you take VAP. So this is the CRBSI and this is the catheter related UTI and this is the VAP. So all these are expressed as per 1,000 device days as a standard benchmark. So if you look at the burden in the middle income, it is high. The CRBSI, the benchmark is usually 4 per 1,000 device days is what is universally sort of accepted as a quality indicator. And if you see here, if it is 0 to 10, you see it is all little higher. The clustering seems to be low, but the other dots you see it is gone up to 20. So that is a sort of burden. And if you look at UTI, the accepted sort of a benchmark is 6 per 1,000 catheter days. And even here, if you see 0 to 10, it is quite clustered, but above 10 also we have. And if you look at VAP, the accepted sort of a benchmark is 18 per 1,000 ventilator days. And if you see here, the clustering seems to be more than 20 here. So basically to say that in middle income countries, it is quite fluctuant across the board with regards to the benchmark indices. So the hard data, if you want the hard data in India, so this is a data that came device-associated infection rates in 20 cities of India. And this study was a huge epidemiological data done between 2004 to 13. Look at the CLABSI rates. So we belong, so like if you take our Manipal hospital, we come in this category. These are the bed strength, less than 200, 200 to 500, 500 to 1,000. So ours would possibly come in 200 to 500 bed, sort of a bed range. And if you look at the CLABSI rate, it is 6.47, which is high. I'm just talking about the hospital strength. And if you look at 500 to 1,000, it's 4.61. More than 1,000, it seemed to be less. So, but the typical hospitals, we all work in 200 to 500 bed strength. The CLABSI rate in this particular data, hard data, was 6.47 per 1,000 catheter days, which is pretty high. And why it is important? Because if you look at this data, so without hospital-acquired infections, if you see the mortality is 6.9% and length of stay is 4.6 days. But if they develop CLABSI, this is the second sort of a row if you look. With CLABSI, the mortality will go up to 23.2%. So it has a bearing on mortality. And if you see the length of stay, it increases to 14.1. This is the hard data from our own country, where if they have healthcare associated infections, in particular CLABSI, and so on and so forth in County. In County, it goes up to 13.5. So length of stay significantly gets prolonged when they develop hospital-acquired infections. And amongst the infections, WAP and CLABSI had a higher sort of a mortality if they develop healthcare associated. So this is the epidemiological data. And the other problem with CLABSI is the resistance pattern. So here very carefully, if you look, the resistance pattern for oxacillin for Staphylococcus was 47.5%. And if you look at Enterococcus faecalis having resistance to vancomycin, it was 15.4%. And if you look at Pseudomonas, the resistance pattern was 50.4. This is, I'm talking about 2014, 13-14 data. And if you look at Klebsiella, 21.8% was the resistance, but I'm sure now this has more significantly increased. And the Acinetobacter, the resistance was 67. So this is the burden we have. So if they develop CLABSI or hospital-acquired infections. So this is only I'm talking about CLABSI. These are I'm not touching about WAP and COUT. So the resistance rates are pretty high. So the type of bugs that affect and cause the healthcare associated infections are all resistant bugs. So that is the burden that we have when we are. So the best way to reduce or minimize this burden is to prevent these healthcare associated infections and CLABSI. So here we'll stick to CLABSI. So I'm sure most of our dear intensivists would have heard of Victor Rosenthal. He has done huge epidemiological studies and he's from Argentina. So this was a huge study, 6-year multi-centric study on short-term peripheral. So he looked at epidemiological burden with peripheral venous catheter bloodstream infections in 727 intensive care units of 268 hospitals in 141 cities of 42 countries of Africa, America. So this is a global data. So they have looked at what is the burden of peripheral venous catheter. And if you look, so I'll just highlight few points. If you see the CLABSI rates in oncology patients with a PVCR is peripheral vessel catheter related bloodstream infections, PVCR. So oncology had the highest. So you can look at the CLABSI rate was 11.1. So the risk of oncology patients developing CLABSI was the highest at 11.1, followed by the burn and followed by neurology patients. I'm sure all the intensivists hearing to this, we deal with a lot of neurology patients, so they are at a higher risk. That's why there is a move towards having a safe catheters for these patients, maybe having, and one needs to get trained in taking care of the PIC lines if these patients have. So this is the sort of a burden globally that we have, even from the peripheral vein catheter related bloodstream infections. So that's about the epidemiology. So basically, epidemiologically, we know there is a huge burden of CLABSI, and our whole resolve should be to prevent occurrence of CLABSI. So this whole talk is on how we prevent CLABSI. So what are the potential routes of infection? So this is the CVC line, nice triple human sitting in the vein. So if you see why the potential routes of infection is not from anywhere outside, it's from within the vicinity. So there are bugs which are colonized at the entry port of the CVC. So that is where the bugs sort of seep in and enter the bloodstream. And the most important is I found the catheter hubs or the caps that we use, they are colonized with the bugs. And during the manipulation, so we would be using those hubs to draw the blood or maybe give some infusions. When there is a breach in that barrier, that is where the bugs also sort of get breached and enter the bloodstream. And the fourth important is the constant manipulation of the catheter hubs. So these are the potential source. So it is not somewhere which comes, bounces from somewhere and jumps into the catheter. It is all present within the vicinity. So our whole effort is to how we minimize the colonization at the entry port, how we minimize the colonization at the catheter hub, and how we take precautions while drawing blood, and how we minimize the manipulations or the handling of this catheter hub. And obviously, there are risk factors which we'll talk. So, what are the guidelines for prevention of this? So, our whole talk is on how we minimize or we prevent CRBS, right? So, if you look at the guidelines, whatever I'm going to talk are endorsed by these. So, CDC has come out with the CLABSI prevention guidelines in 2017. So, whatever that I would be talking is justified or substantiated by these global agencies, and this is International Nosocomial Infection Control Committee. It's called INIC. So that also came with guidelines in 2017. And INS is the nursing standards, infusion nursing standards, sort of a guidelines that came in 2021. Then there was the Society of Healthcare Epidemiology of America, which is called SHIA, which came out in 2022. And all these are endorsed even by Indian Society of Critical Care Medicine in 2000. So these are, so whatever guidelines we're talking is substantiated by these global sort of agencies, and our ICU society also endorses that. So what we believe is we need to have bundles. Okay, so why bundles? When we say bundles, so what we understand by bundles is it's a set of certain evidence-based medicine or evidence-based justified processes which may incorporate 3 to 5 steps. It's a very simple bundle is which is substantiated by evidence-based medicine. We put in 3 to 5 processes and we collectively put these processes as a package and apply to the patient. And this has shown to improve patient outcome and it has shown to improve the processes that are involved in preventing and mitigating CLABSI. So it is just a set, it is a set of rules, if you may have to say, set of rules or set of processes or set of postulates or set of sort of a laws, whatever you can call, we put together, package it, and apply to the patient with an intent that we reduce CLABSI and improve patient outcome. So now we need to understand what are the risk factors for. We saw the potential routes of bugs entering the veins. What are the risk factors of someone, a patient developing CLABSI? The important risk factor is having a line, having a central venous catheter. The central venous catheter, either in ICU or in non-ICU setting, is a potential for developing central line associated bloodstream infection. And post-surgical patients are found to be at a higher risk of developing CLABSI. And most important, this is the subgroup of patients we tend to see in hospitals. Patients coming to hospitals for dialysis with a indwelling catheter. These patients are at a risk for developing CLABSI. And we saw from the global epidemiological burden, oncology patients are at a highest risk of developing CLABSI even from the peripheral vein, which means they develop bacteremia. They are at a risk because they are immune challenged, immunocompromised. They are at a higher risk of developing peripheral, even with peripheral vein, they are at a risk of developing CLABSI. So peripheral vein catheter bloodstream infection also is high in oncology patients and someone with a PIC catheter, PIC line. So they are also at a higher risk of developing. So our efforts is how we take care of these catheters. Okay. So when we look at again the way why this happens, we saw the previous picture, the potential sites of infection. So when someone is in a hospital for a longer time, they are at a higher risk of developing CLABSI. And someone with neutropenia, they are at these are the risk factors within the patient. So when you talk about risk factors, it is the patient sort of determined risk factors and it's a catheter related risk factors. So maybe for all the trainees, you have to divide patient factors and catheter factors. Patient factors, longer the patient is in ICU or patient having neutropenia or at a higher risk or obesity. Obese patients are shown to be at a higher risk of developing CLABSI, maybe because the catheter care may be difficult or so on and so forth. And this is most important, which possibly in India we all face this nurse patient ratio because we know we are always challenged with the sort of a 1:1 sort of a ratio we could maintain in the ICU. So when ICU gets busy, the nurse may be looking after 2, 3 patients. This puts the patients at a highest risk of developing CLABSI. So these are all some of the patient and environmental factors. When it comes to the catheter related factors, the longer the catheter is in the vein, the higher is the risk for CLABSI. And as I mentioned, colonization at the skin entry, at the port of enter, the site of enter of the catheter, colonization. So we need to keep the area where the line is entering sterile and we need to take aseptic precautions. So colonization at the site of entry of the catheter is at a high risk. And having multiple humans in a catheter also is a risk for developing CLABSI. And as I showed you in the previous, so the colonization of the hubs during sort of a drawing the blood or during infusion of anything, when there is a breach of the barrier, it's at a high risk. And someone who is receiving TPS, they are at a higher risk of developing CLABSI. And someone who is receiving blood transfusion also is at a much higher risk of developing CLABSI and frequent handling of the hubs. So these are the catheter related factors. So someone who's on TPN, so that's why we are so much worried when someone is receiving multiple transfusions, they are at a risk of developing CLABSI and handling of these catheters. So this is pictorial representation. So all trainees in exams, they ask, let's put this picture as the risk factors, catheter related risk factors for CLABSI. So this would pretty much give a conceptual sort of a message to examiner as well and for you also to be very clear. So now we'll slowly move to recommended strategies to prevent CLABSI. So all those guidelines we saw, SHIA or CDC or INIC or INS, so they have categorized the strategies into 2 essential practices in 2014 and additional approaches. So You have to categorize it into two dimensions, essential and additional approaches. So they have categorized into three sort of a timelines: before insertion, at insertion, and post insertion. So before insertion, the key thing is to have a checklist. So all these guidelines endorse that one should have a checklist and should have a clear indication for placing a indwelling catheter or for putting a central line. So one should have a clear indication, and not doing it when there is no indication is a very important thing. And understanding the risk profile of the patient, whether the patient is on dialysis, patient is having neutropenia, patient is sort of looked at as staying for long in the hospital, obese patients. So categorizing the risk of the patient, basically maintaining the checklist is very important to try and understand the risk profile and the care and maintenance of these catheters with a transparent dressing, so that the entry port of the catheter nowadays the agreed sort of understanding is it should be exposed. So we should be able to see the entry port, so that if there is any redness, so one could act upon it and prevent the colonization and minimize the translocation of bacteria, and taking strict infection control measures. And every healthcare personnel looking after the central line should be credentialed, should have undergone training for the care of these sort of the catheter. So constant education has to happen, and credentialing of that nurse, that she has gone through a structured sort of a training as to how she or he has to look after the central line. That also has to be put in place. And re-education, education has been emphasized as the only way as to how we sensitize the healthcare personnel who is looking after the patient to take care of these central line is what has been emphasized. And they have even emphasized the role of simulation training for taking efforts to prevent this CLABSI. So these are some of the before insertion, you need to have this process. You have a clear indication, understand the risk profile, and healthcare personnel should be credentialed in sort of taking care of these lines, and good infection control practices, and some sort of a simulation. So that is the gist of before insertion. And before insertion, certain processes in ICU is patient should be undergoing chlorhexidine body wash. This also is emphasized, and I'm sure all my trainees in my ICU now, we give chlorhexidine bath twice a day is what we recommend. So chlorhexidine body wash has to be given for these patients, but safety less than 2 months of age is unclear, but more than 2 months it is considered safe. And at insertion, so before insertion, those checklists and chlorhexidine body wash. At insertion, what is recommended is there should be an independent observer from the infection control team who is observing when the procedure is being done with a checklist. So she or he has to maintain a checklist whether all the infection control practices are being adopted whilst they're inserting line, and he or she should be empowered to stop the procedure if there has been any breach in the infection control sort of a processes that they have breached whilst inserting the central line. So this is very important, and I'm not sure how effectively this may be happening across the board. But at least in my ICU, we have an infection control nurse who keeps watching when we are doing procedures, and she or he she'll be making a note of whether all the aseptic precautions are being taken care of as a checklist. And good hand washing cannot be overemphasized, and good universal precautions. When we say universal precautions, it is cap, goggles, mask, and gown. So as much as possible, all these areas have to be covered. So remember, from head to toe, cap, goggles, mask, and gown has to be there as a universal precaution, and a glove. And it is sort of preferred in ICU settings. Subclavian vein seems to be having the lowest sort of infection rate. It is desirable that subclavian could be thought of, but other routes, but there's no hard data, but there is a preference towards subclavian for ICU, even as a part of this guideline. So when you look at the site where we tend to put central venous catheter, in pediatrics, it is accepted that femoral could be considered as safe. But as I said, in ICU, subclavian is preferred. But then any other line, you need to take the precautions to prevent CLABSI, so internal jugular or PIC. So these are the typical areas that we put in adults. So at insertion, so the what is what does the guideline say? That we need to use CVC kits. When we say CVC kits, there is de-emphasis on someone using needle separately, guide wire separately, catheter separately. So it is advisable that a kit of this nature is utilized for all CVC insertions and not separately. And even the guidelines do suggest using ultrasound for putting all CVC. I'm sure all the intensivists listening to this know that it is almost tantamount to malpractice now if we are doing any procedure without the use of ultrasound. But ultrasound has clearly shown it reduces the risk of non-infectious complications, like making multiple punctures is associated with the increased risk of CLABSI. So that's why we use ultrasound to minimize multiple puncture sites because they can act as a nidus for CLABSI to happen. But one should take care that there should not be breach in the aseptic technique when someone is using ultrasound. That care also has to be taken care is what has been emphasized. And 2% chlorhexidine has to be used for all your aseptic precautions or the scrubbing or preparing the part, preparing the skin prep has to happen with 2% chlorhexidine. And maximum sterile barrier has to be used, which is going from head to toe, cap, goggles, mask, gown, and gloves. And it is suggested, the guidelines suggest large full body drape has to be used. So you should, as much as possible, the larger the drape to keep the whole surrounding sterile is what has been advised. So large full body drape is what has been recommended. So that's about insertion. So at insertion, I'm sure every intensivist is an expert, but make sure you use a good drape, make sure there is no breach, make sure, and it is desirable the performer can have an independent observer who's making a note and trying to give a feedback if there has been any breach while doing the procedure. So coming to post insertion, this is very important because many of the doctors, sometimes we may be little agnostic to all the care that needs to go on. So now gone are the days where we put Tegaderm or where we put the Dynaplast. We used to put Dynaplast before. So now it is recommended that we put a transparent sort of a dressing where the insertion site has to be clearly seen so that if there is any redness or anything is seen, immediate action can be taken to make it sterile and prevent the colonization of the bugs. And in places where your CRBSI rates are more than 4 per thousand catheter days, it is advised that you can use chlorhexidine sort of a sponge that can be present at the insertion site. And some small studies have shown that it reduces the colonization. And these dressings have to be changed every 7 days, or if they get soiled, if there is any blood seen at the entry port, many a times during rounds, I see that this is the site as having some blood stain. We have to take cognizance of that and tell the nurse to change the dressing because any presence of any blood clot or anything there becomes an iris for infection. As that's why you see it has to be changed every 7 days if it is clean. But if it is soiled, what does soil means? Means obviously if there is a blood clot or anything, it has to be changed. Or if you have a gauze, because you are not able to see what's happening inside, gauze has to be changed every 2 days, or if gauze is soaked with whatever blood or so on and so forth. So this is the post insertion. This is very important for all our tier intensivists. Half of the uh, catheters that are connected to the connectors are colonized. So that is very dangerous. So all the connectors that are connected to the catheter are colonized. So before using this cap, it has to be sterilized with at least 5 seconds with a wipe, sterile wipe. So now that is where the whole concept is evolving. How effectively nurses are cleaning the caps with the sterile swab or with a spirit swab before they administer medication is what sort of is a limiting factor for preventing CLABSI. So I'll talk about it. So what are the newer innovations that has come? So post insertion, so all these drip sets, what we use, routine replacement is not needed. All the drip sets that we connect to the central venous catheter, they don't need routine replacement, but they have to be changed every 7. So 7 days is what you should. Dressings have to be changed 7 days, and even the drip sets have to be changed every 7 days. And non-essential catheters should be removed. There should not be unnecessary catheters being connected to the drip sets connected to this. So if you have 3 lumens, you don't have to connect all 3 lumens to some sort of a line. If they are of no use, just keep it closed. And surveillance of CLABSI has to be done time to time to see how your rates are progressing with all these efforts. So now we're coming to a little interesting part. What are the additional? So those are all run of the mill sort of a thing which most of you would know and nurses would be doing at a very intuitive level. So what are the additional approaches that we need to do? So there are catheters which are antimicrobial impregnated catheters. So where do we use it? So the antimicrobial impregnated catheters are chlorhexidine, silver sulfadiazine, and minocycline rifampicin. These are the two sort of a catheters that are available now. Indications. So you don't use this routinely. Indications is where if your institutional CLABSI rates are more than the accepted benchmarks, like you saw the Indian rate sitting at 6 or 7. If it is that, maybe if it is more than your institutional goals, you may have to consider using this antimicrobial impregnated, or typically non-co patients where you may have difficult IV access and where the risk of recurrent CLABSI is high because they have low platelets, febrile neutropenia, where we cannot keep on replacing. Maybe that is a subgroup of patients where they may benefit from using antimicrobial impregnated catheters, or someone who has CLABSI and which has a severe repercussions or ramifications, like if they have prosthetic valves or if they have a sort of a any prosthesis anywhere, because you wouldn't want MRSA to go and infect those prostheses. So these are the situations where you may have to consider these antimicrobial impregnated catheters. So for that, now there is a new sort of a thing where chlorhexidine gluconate dressings have come. So this is something which is something good for all our intensivists to know. So this Tecardum chlorhexidine gluconate dressings that have come, that is something that could be adopted to prevent the colonization at the site of the entry of the catheter. So then there are these antimicrobial locks. Okay, so antimicrobial locks is something that could be used again in places or situations where the CLABSI rates are high. And there is a proposition that where risks are high, the tissue plasminogen activator RTPA once per week can be used in dialysis catheter. This is to prevent the clots to form because always the blood clots are the ones which act as a nidus for CLABSI. So this could be thought of. So the new innovation that is happening is you are having now antiseptic containing hub connectors, which is called antiseptic sort of a hub connectors, where these connectors have antibiotic within them, which prevents the sort of colonization. Okay. So these are called ABC, antimicrobial barrier caps, ABC. It's a very easy to remember, antibiotic or antimicrobial or antiseptic barrier caps. So they prevent colonization at the port of entry of these hubs. And it is desirable that you have an infusion team who are constantly monitoring how the lines are being taken care of. And these are pretty much done by our infection control nurses. So it is good to create an infusion team or IV access team within the hospital. In Manipal, we do have these teams. So, and they do have a very active role in trying to take steps and train nurses to prevent CLABSI. And there is even a submission that one could think of using these antibiotic ointments where the risks are high, where you foresee the patient is at a much higher risk. You can put chlorhexidine ointment at the site of entry of this. So these are some of the additional steps that one could embark upon in situations where your CLABSI rates are higher than your institutional goals. So, and what are the things that should not be done in CLABSI? So, routine antibiotic prophylaxis, where just because saying that patient is at a high risk of CLABSI, I give prophylaxis, that should not be undertaken. And routine replacement, like every 7 days, I'll replace a central line because there is a risk of CLABSI, there is no rule. So, these are things that should not be done. So, that is about the germane sort of an approach which is endorsed by all these sort of international global associations, all the standard run-of-the-mill sort of measures and processes that needs to be adopted to prevent CLABSI. So now I'm coming to the more interesting bit for our intensives, which are the studies. So what does the studies say? And all the innovative studies. So this is a very good study, randomized controlled trial of chlorhexidine dressing and highly adhesive dressing for preventing CRBSI. So we are talking about what are the steps that we can incorporate in ICU to prevent CLABSI. So there are these Tegaderm chlorhexidine gluconate dressings which are available. And this study was done in France, published in 2012. So if you see the non-chlorhexidine dressing versus the chlorhexidine gluconate dressing, the CLABSI rate was significantly less. Which you see it was statistically significant by the use of chlorhexidine dressing that you could reduce the CLABSI rate from 1.3 to 0.5 here. And you could even reduce the colonization from 10.9 to 4.3 by using chlorhexidine gluconate dressings, right? And this is a very good innovative sort of a strategy. Sustained reduction of catheter-associated bloodstream infection with enhancement of catheter bundle by chlorhexidine dressings over 11 years. So this is done by again a Swiss study where if you see they have shown that CRBSI rate came down from 1.12 to 0.42 with the chlorhexidine sponge I showed you. I showed you that sponge at the entry. But when they use chlorhexidine gel dressing, it was reduced furthermore to 0.1%. So this possibly is something that we should all adopt to mitigate the risk of CLABSI in a high risk ICU environment because all our ICU patients are at a high risk of developing CLABSI, more so when the nurse patient ratio is always challenged in our station. So chlorhexidine sort of a dressing is something that we should possibly adopt to reduce the risk of CLABSI. And this is very interesting. So for all our intensivists, so if you look at the guidelines suggest that you need to clean the hubs with the spirit swab for more than 5 seconds. And studies have shown that people are not doing that. So what they've shown is in US, they showed compliance is less than 10%. So let alone in our country, it may be much worse than this, that people may not be doing this cleaning of these catheter valves. And in Brazil, they showed compliance happened only 38.7%. And non-compliance pretty much occurs at 31%. So this is not something we can have faith on, that nurses would do this spirit swab. That's why they come with this ABC, which I said, which is antiseptic barrier caps, ABC. So this is called Curos, so which is come from some commercial companies. It's called Curos ABC, antiseptic barrier cap ABC. So you see there is some sort of a sponge inside which possibly has antimicrobial, and that could be put in to all the caps so that the colonization at the ports do not happen. And this ABC, antiseptic barrier caps are suited for dialysis catheters, for all the needleless like clave connectors you can use, lever caps you can use, and stopcock. So it is suited to fit into all these sort of different sort of caps that we use in ICU. So is there evidence for that? So there is this beautiful evidence that comes from this Dutch meta-analysis. So there is a Dutch meta-analysis, antiseptic, to see this ABC, antiseptic barrier cap to prevent central line associated bloodstream infection, systematic review. So this is a good evidence that we have and published as late as 2022. So here they took 15 studies and they took 2,73,993 catheter days. So it's a very huge sort of a data that they have looked at. So here they have looked at antiseptic barrier caps, CLABSI 391, standard 620, that was statistically significant. And you could see that using the spirit swab, scrubbing the hub, and to ABC, there was a significant reduction of the CLABSI rates by 35%. And here they even looked at the cost savings. The cost savings was $41,000 per thousand catheter. So possibly these are the two things that we should look at adopting. So chlorhexidine, gluconate, or with in as an adjunct to all the standard sort of processes that need to be put in place. So these are the additional things that we could possibly adopt: chlorhexidine, gluconate dressing, transparent dressing to prevent, or chlorhexidine sponge, and antiseptic barrier caps because it is shown that the portal of entry is the usual culprit for all the colonization, and this is a good study to substantiate that it has a role in mitigating the CLABSI rate. So, and as I said, preventing CLABSI is a quality indicator, and this is our bundle in my Manipal ICU. This is the bundle we have, CRBSI bundle. I've taken the bundle from our own bedside. So if you see this bundle, we have hand washing with chlorhexidine, catheter hub disinfected. So we have it in our bundle, catheter hub disinfected before spirit swabs, and administration sets replaced according to protocol, and dressing changed according to protocol. This is separate. So this is the protocol we have right now in our ICU, and this is a quality indicator. And this is a WAP protocol we have, WAP bundle rather. So I won't be talking. So the benchmark, as I said, was 4 per 1,000 CBC days. For catheter related UTI, it is 6 per 1,000 catheter days. For ventilation, it is 18 per 1,000. These are the CDC sort of a benchmark. So thank you, friends. So hopefully that covered most of the salient aspects of preventing CRBSI. So I request all our esteemed listeners to attend our signature event, JIC, happening from 18 to 20th October. So request all our listeners to submit their valuable work to Journal of Acute Care. So visit my website. So have patience. All things are difficult. So have patience and preventing CLABSI you need to put in a lot of processes in place. So thank you, Anand.